Hello, uh, I'm Dr. Hiba Qasim, and I will go through the chromosomal study and karyotype analysis practical class. This is part one. The learning objectives include the to realize the specialty of cytogenetics as part of the practice of medical genetics, to recognize the different steps involved in karyotype preparation in a cytogenetic lab, to identify the steps that are involved in the preparation, and then to move on to the chromosomal analysis and how to classify the chromosomes based on size and centromere position, to identify the different abnormalities in a karyotype, and to analyze the indications to do karyotype, and as a skill, you will learn to interpret normal and some examples of abnormal karyotypes, and you will also be able to describe a karyotype using the symbols according to the International System for Cytogenetic Nomenclature. For short, we call it ISCN. So, what is a karyotype? Well, we will learn that a karyotype is a systematized arrangement of chromosomes according to certain criteria that we will learn about very soon. And the karyotype is used as a diagnostic tool to show changes in structure or number of chromosome. It's like a test, laboratory test, that you get a result about any changes present in the chromosomes. To do a test, you need a sample. So, what is the source of samples that you can use to prepare a karyotype? The most common used is blood sample taken from a vein, and this is the most commonly used sample, or a skin biopsy can also be used, where it is cultured, grown in the lab in vitro, and the dividing fibroblasts will be used for the chromosomal analysis and the karyotype preparation. It can also be done for fetus inside the uterus by taking a sample from the amniotic fluid surrounding the fetus, or early in pregnancy, the sample can be taken through a transabdominal syringe that obtains a sample from the placenta, and this is a chorionic villus sampling, and it is used in the first 12 weeks of pregnancy for intrauterine diagnosis of chromosomal abnormalities. The chromosomes are tested in the metaphase stage of the cell cycle. So, whatever the source of your sample is, you need to bring the cell in division and then capture the cell when it is in metaphase, because at this phase of the cell cycle, the chromosomes are maximally condensed and therefore can be easily studied. How is the karyotype prepared? We started by the sample collection and then the culture of the cells and stimulating the cells to divide, because as we mentioned that the cells can be only examined when they are in cell division in the metaphase stage. So the cells will be grown in cultured medium, having nutrients and having a stimulant to divide. They are incubated for 2 or 3 days at 37 degrees centigrade in an incubator supplied with 5% carbon dioxide. And then a certain chemical is added in order to stop the cell division in metaphase by paralyzing the mitotic spindle. Then the cells are collected and the culture medium is removed, and the cell pellet which remains in the bottom after centrifugation, after turning round very quickly, the pellet will then be resuspended in hypotonic solution to allow the cells to swell up. Ballooning of the cell will happen, and the cell membrane will rupture, and so the chromosomes of the cell can spread out, as we will see in the following slide. And then the cell and a fixative is added in order to keep the cells, the chromosomes, in position and as they are, and therefore be able to study it on when stained and dropped on a slide, so they can be examined by the light microscope, and the picture of the metaphase is taken to be used for karyotype preparation, and analysis of the chromosomes will be possible. So here is the metaphase spread of one of these. These are other cells. These cells are in interphase, and this cell has got its membrane ruptured by the hypotonic salt solution, and the chromosomes spread out beautifully, so they can be examined as such. Now we get this picture after taking it by a digital camera, and you can see that the chromosomes are banded, which means they show a pattern of alternating dark and light bands، زي ما يكون مقلم غامق وفاتح. ده ايه اللي خلاه يبان بالطريقة دي؟ ان احنا عملنا treatment of the cells with trypsin, which is a proteolytic enzyme that digests the proteins surrounding in the chromatin, and followed by staining with GIMSA. And so you see the chromosome as banding, and they are called G banding of the chromosomes. And this is the standard method for chromosome study, and we call it the G banded karyotype. This is the gold standard for karyotype. Now, the karyotype, in order to analyze the chromosomes, you always need to refer to a reference, and this reference is called the ideogram. So this picture here is of an ideogram, which is the diagrammatic representation of a karyotype, which shows the positions of the regions and the bands of each of the G-banded chromosomes from 1 to 22 and the sex chromosomes. So this is used like a reference that you compare to in order to identify the different bands and name them on a chromosome. So the karyotype is defined as systematized arrangement of the metaphase chromosome. The picture that we have just seen of a metaphase G-banded chromosomes will then be arranged systematically in order to produce the karyotype. And the chromosomes will be arranged in groups from A to G. According to what is this arrangement? It depends on 3 things. First, the length of the chromosome. It starts chromosome 1, the longest chromosome, and ends with chromosome 22, which is the short chromosome. And number 2, the second factor, is the position of the centromere. The chromosomes that are similar in the position of the centromere are grouped in one group together. So size and position of centromere make a group, they make a group together. Number 3 is the banding pattern, which is the alternating dark and light bands that is compared to the ideogram to identify each chromosome pair. So this is the outcome that we get. This is the karyotype. As you can see here, chromosomes are clustered or grouped together in groups from A to G. First group are the longest chromosomes, and their centromere is all in the middle, and this includes chromosome 1 to 3, so they are called metacentric long chromosomes. The second group, 4 and 5, are also long chromosomes, but the centromere is shifted more to the P arm, and so you have a short P arm in comparison to the much longer long arm, so they are sub-metacentric long chromosomes. Then you have the group from 6 to 12, and these are intermediate length, and their centromere is sub-metacentric. Then group D, they are intermediate in length, but they have the centromere at the peripheral end of the chromosome, so they are called acrocentric chromosomes. They don't have short arm, only satellite is present and connected to the centromere by a stalk. So these chromosomes 13 to 15 don't have any P arm, only satellites. This group here are short and they are sub-metacentric. This group here are also short, but the centromere is in the center position, so they are metacentric. And this group here are short and they are acrocentric. The 21 and 22 acrocentric like this group, so they don't have short arm. And then the X and Y chromosomes, they are the sex chromosomes and they are grouped together at the end of the karyotype. And so this is a normal karyotype, and the sex here is of a male. Okay, so we now know how to prepare karyotype. We know the definition of the karyotype, and we know how do we prepare the chromosomes in order to produce the picture of the karyotype. Now, as future doctors, you should know when will you ask for your patient to do a karyotype. These are the common indications for karyotype testing. A couple can come complaining of infertility. They can be married for 2 years and they fail to conceive or to have children, and there is no organic explanation, there is no health problem that can explain this infertility. Here you will ask for a karyotype analysis and you will ask both partners to do the karyotype testing. You don't ask only the wife and you don't ask only the husband, because this can lead to social problems. So at the same time, ask for a karyotype in order to not to have any misunderstanding if you ask one partner only to do it, and they may think that they have the reason, they are the cause for the infertility. So from the very beginning, ask both parents to do it at the same time. Or If there is a history of miscarriage, which means disruption of the pregnancy and spontaneous abortion. Also, especially when it is repeated, then you can ask for a karyotype analysis either from the product of the abortion, or you can ask both parents, especially if repeated abortions happen. Then you can ask for the karyotype analysis again from the wife and the husband. A karyotype is also used to test the cause for abnormal live birth with congenital abnormalities. Again, if there is no reason to explain the occurrence of congenital abnormalities, like any disease that the mother suffered from during pregnancy, or if she didn't take any drugs during pregnancy, or if it is repeated in the family, then you also ask for a karyotype from the baby. The fourth reason to ask for karyotype if you get a child having mental retardation, and again there is no reason to explain this mental retardation, like history of prenatal or natal exposure again to any trauma or to drugs or to infection like viral infection. So if there is no reason, then you may suspect chromosomal abnormality, because it is the commonest cause of mental retardation in children. The fifth cause is when there is a newborn and the external genitalia is ambiguous and you cannot really determine for sure the sex of the baby. So a karyotype will be done in order to determine the genetic sex of the newborn, to determine before stating the sex, and it can be said wrongly, and the baby can be grown up as opposite to its sex. Also, an important reason, as we will see in the coming slides, is when you have abnormal sexual development and delayed puberty, there are common causes for delayed puberty that relates to chromosomal abnormality, as we shall see. In cases of cancer, and especially the hematological malignancies like leukemia and lymphoma, the genetic testing for chromosomal abnormalities through the use of karyotype is also requested for diagnosis and for follow-up of the patients. Okay, now we come to what type of chromosomal abnormalities we can see in a karyotype. Well, chromosomal abnormalities can affect the autosomes. These are from chromosomes 1 to 22, or it can affect, of course, the sex chromosomes. Usually, the effect of the sex chromosomes is much milder than the autosomes, and mainly it is related to sexual development. What types of chromosomal abnormalities can we see? It is either numerical, if there is change in number of chromosomes, or structural, if there is change in the structure of the chromosome. Same thing with the sex chromosomes. This diagram here shows is a summary for all classification of chromosomal abnormalities. So again, you can have a numerical abnormality, a structural, or you can have different cell lines, one that is normal and one that is abnormal, having any of the two chromosomal types of abnormalities. So the different cell line is the mixoploidy. There are two types for mixoploidy, and this includes the mosaicism if it develops from the same zygote, during the mitotic division after formation of the zygote, or chimerism, which originally was a twin pregnancy and the two uh, fertilized ova when they in the early phases of cell division came close together and there was mixing of cells between the two uh, twins. Now, the numerical chromosomal abnormalities and the structural chromosomal abnormalities, we will go through them individually throughout the practical class. So let's have a go and see how we can describe a karyotype. The description of the karyotype is based on description of the number of the chromosomes that you can see in the picture of the karyotype and the sex chromosome, and you look for any abnormality. So here you have a metaphase that has been arranged into the groups of chromosomes as we described earlier, and then we will be looking for the number of chromosomes. So you can see here each pair is present for all chromosomes except this chromosome 8. You have 3 copies instead of 2 copies. And here you can look for the sex chromosome. You have an X and a Y. So this is a karyotype of a male. Now we get a closer look at the karyotype and we compare each pair of the chromosomes. And when you find a difference between the two homologous chromosomes, you look carefully for the type of change, structural change that is present. You can see here that this is the long arm is present, but most of the short arm of chromosome 1 is deleted. So there is a break that happened here in the P arm, and the terminal part of the chromosome is lost. So this karyotype shows 2 abnormality: numerical abnormality, which is the trisomy 8, and structural abnormality, which is the deletion of chromosome 1. Now, how can we describe this? The description according to the International System of Cytogenetic Nomenclature starts with the number, comma, sex chromosomes present, comma, and abnormality present. And when we have 2 abnormalities, we start by the numerical abnormality first, followed by the structural abnormality. So let's have a go. This karyotype is described as 47, just by counting, because extra chromosome is present here, and it's a male, XY, and the type of abnormality which increase the number of chromosome is plus 8, trisomy 8, comma, the structural abnormality is deletion in chromosome 1, P. So we want also to be familiar with some terms. Euploidy means U is like good, is like normal. So it is presence of complete chromosome set. And the complete chromosome set is 1N, that is 23 chromosomes in the gametes, in the ova and the sperm, and it is 2N, that is 23 times 2 is 46 chromosomes in the somatic cells. Now we come to the abnormal number of chromosomes. First is the polyploidy, and the polyploidy is a simple multiple of the haploid chromosome set. Poly means many, and ploidy is the chromosomal set, which is represented by the N. So the normal uh, polyploidy, the only normal polyploidy is the 2n. And the 2n, as I just mentioned, is the 46 chromosomes in the somatic cell. But if we have a 3n, this is called triploidy. And the total number of chromosomes here will be 69. And the sex chromosomes can be any of three possibilities, either 3X chromosomes, or 2X chromosomes and 1Y, or 1X chromosome and 2Y chromosomes. Another example of polyploidy is the tetraploidy. And the tetraploidy, tetra in Greek means 4. So it's 4n. That is 92 chromosomes, either 4X chromosomes or 2X and 2Y. Now, you may ask yourself, what is the cause of the triploidy? And you may also ask yourself, what is the cause of tetraploidy? And I'm sure you can answer these two. You can have answers for this because you have gone through your lectures earlier. If not, then revise it. So, this is a karyotype. And is it for triploidy or tetraploidy? Let's have a look. We have 3 copies of each chromosomes. Accordingly, it's a triploidy. So the total number will be 69 chromosomes. How about the sex chromosomes? You can see they are the X chromosomes. So, comma, X, X, X. So this is description of this karyotype, and the pathology here, or the name of the abnormality here, is triploidy. Can we have a clinical example for the polyploidy? There is a condition which can present by a female who was pregnant, and then she started to have bleeding. So it was suspected that she has abortion. So immediately she was asked to do an ultrasonography. And this picture shows that the placenta normally should look like this. But the presence of vesicles, as you can see here, shows that the placenta is of a vesicular type. And this is the pregnancy of a partial vesicular mole. You have an abnormal, very small baby and an abnormal placenta formed of vesicles instead of the normal appearance of the placenta. This condition is called partial vesicular mole. And it results from triploidy, and it only happens if the extra chromosomal set is coming from the sperm. So it is of a paternal origin. And this can happen if the sperm was diploid due to failure of reduction division in meiosis 1 during spermatogenesis, or it can result from the rare incidence of dispermy, which means fertilization by 2 sperms. The second type of chromosomal abnormality is called aneuploidy. And aneuploidy, and if it comes before euploidy, then it is the opposite of euploidy. So let's remember together, euploidy was a complete set of chromosomes, N in gametes and 2N in somatic cells. So aneuploidy is not a complete set, but there is an extra or loss of one or more chromosomes, and it does not involve the whole set of chromosomes. So it's not like polyploidy. If there is loss of one chromosome and you have only one copy instead of a pair of chromosomes, we call this monosomy. And monosomy, if it happens in autosomes, then it will be lethal and the embryo cannot develop and it will cause early abortion. The only live birth that has a monosomy is the Turner syndrome, in which there is a 1X chromosome, and this can survive, although most of the cases are lost in abortion, but it may give a live birth, and the result will be a Turner syndrome. The other type of aneuploidy is trisomy, and here there is an extra copy of a chromosome. So there will be 3 copies of an autosome or a sex chromosome. If the trisomy affects an autosome, it will not be possible to develop a normal baby, and it is usually ending in abortion. But there are 3 autosomes where trisomy can result in a live birth. And these are the chromosomes 13, 18, and 21. Why especially these 3 chromosomes that you can have a trisomy from them? Because they have the smallest number of genes. And so the effect will be less damaging to the development of the baby than the other autosomes. However, still with these chromosomes, the rate of abortion is very high. And the smallest chromosome with the least number of genes is chromosome 21, and that's why the Down syndrome is the commonest type of numerical chromosomal abnormality that we can see living even to adult life, up to the age of 40 or 45. Down syndrome can survive. Trisomy can also affect sex chromosomes, and you can have females with 3 X chromosomes, or you can have Klinefelter with 2 X chromosomes and 1 Y chromosome, or you can have the extra Y syndrome where you have males with 2 Y chromosomes. The trisomy affecting sex chromosomes is less severe in its manifestations than the autosomes, and they are mainly concerned with the main effect will be on the sexual development and fertility. Let's have a go and describe this karyotype. Again, start with the number. You have a pair of each chromosome in group A, B, C, D, E, F, G. Sex chromosome, you only have an X chromosome. So the answer is 45, X. This karyotype is a karyotype of Turner syndrome. The Turner syndrome has a phenotype of a female and have some characteristic features, like the webbing of the neck, the short stature. They are usually less than the 5th percentile, so they are quite short, and they have barrel-shaped chest. They have wide spaced nipples, and they have a carrying angle at the elbow, so they cannot stretch their arm لو فردوا ايديهم كده ما تلزقش في الترنك عشان في angle هنا carrying angle at the elbow. They also have some pigmented spots in the trunk and on the face, and they have edema of the feet. And the most important manifestation in the Turner syndrome, other than these features that we can see, is the delayed puberty, because the ovaries are atrophied and they are called streak gonads. Streak ovaries, they are ovaries which is not functioning, is not producing ova, and is not producing hormones, so it is formed of fibrous tissue. Now there are different types of Turner syndrome. The most common type is the one with the monosomy X, where all the cells of the Turner have just one X. There is also the mosaic type of Turner syndrome, where there is a mixture of cells. Some are normal with two X chromosome, and some of the cells are having a single X chromosome. This type of Turner syndrome happens after fertilization, and the two gametes were normal, and then in the early division, some of the cells lost one X chromosome and continued with monosomy X, and the remaining normal cell line continued division, and it ended up with a mosaic Turner. Also, we can have one of the two X chromosomes having a structural abnormality, such as isochromosome of the long arm of X chromosome, or there may be a deletion in the one of the X chromosome, and it appears as the ring chromosome, ring X. Can you try to write the karyotype of a Turner with an isochromosome X? So how about the number here? You think it's going to be 45 or 46? The isochromosome will be counted as a chromosome X, and we have a normal X chromosome. So the number will be 46 XX, but one of the X chromosomes is an isochromosome long arm, which means that the X chromosome is formed of two Q arm instead of a P and a Q arm, due to the horizontal division of the centromere instead of vertical division in one of the two gametes. How about this, the karyotype of this child? You can see here that we have a pair of each chromosome, except chromosome 21. We have trisomy 21. And the sex of this child is a female. So this is a case of Down syndrome. Trisomy 21 results in Down syndrome. And you can see here the facial features of Down syndrome, which is the epicanthic fold, a fold of skin covering the inner angle of the eye. And that's why in the past they were called Mongolism, because they represented the facial features of the race that in the past was called Mongols. And you can see here that the mouth is open because it is small, and so the tongue is protruding from the open mouth, and there is depressed nasal bridge. There is a big receding forehead, and their hair is silky and these are the features that are seen from this picture, but of course there are other features that you will learn about from the TBL presentation. So what are the genetic types? Is it only trisomy 21? The trisomy 21 is the non-disjunction type, which results from non-disjunction. Usually it happens in the ovum, and it is usually happening with advancement of the mother age. كل ما سن الأم بيكبر كل ما بيبقى فيه ريسك عالي إنها تجيب داون سيندروم. عشان كده أكتر من 40 سنة بيبقى المفروض البريجننت فيميلز بيعملوا prenatal diagnosis to exclude any numerical chromosomal abnormalities, because it's very common to happen with increasing the age of the mother. يبقى ده الكومنست تايب اللي هو بيبقى فيه السيلز كلها بتاعة الداون سيندروم فيها trisomy 21. في كمان the translocation type when the chromosome 21, an extra copy of chromosome 21 may be attached to any of the acrocentric chromosomes زي في الجروب G 13, 14, 15 أو attached to chromosome 21. And the third type is the mosaic type, and this is the least common. Okay, so that's how it is written: 47, female XX, plus 21. There are other examples of the autosomal trisomy, which is trisomy 13, trisomy 18. Trisomy 13 is called the Pateau syndrome, and this is a picture of a Pateau syndrome baby. You can see there is mainly midline abnormalities in the development, and they have severe abnormal brain development, small eyes, and widely separated eyes. Sometimes the eyes are absent, and there is cleft lip and cleft palate, which means the fusion in the midline did not happen in the lips or in the palate. They also have extra finger next to the little finger, and they have commonly congenital heart disease, maybe also renal abnormalities, and the condition is usually fatal in the early months after birth. And most of the cases of the trisomy 13, they may be lost as miscarriage, and if they are born alive, they are usually it's usually fatal because of the severe abnormal development of the brain and the internal organs. Again, the commonest type is the non-disjunction type, but also you can have translocation type or mosaic type. The Edwards syndrome, this is a picture of Edwards syndrome, the trisomy 18. The characteristic feature here is you get a rocker bottom heel, which means protrusion in the heel that can even be seen in the ultrasonography prenatally before birth, and they have spasticity, and they are always crossing their legs. They cannot stretch out their legs. They have clenched hands. It means that the hands are always the hands are always closed, and the baby cannot open it, and it's difficult to open their hands. They have small head, microcephaly, and the head is usually protruding from the back. So there is occipital prominence, and also this is fatal in early life because it's usually associated with abnormal development of the brain and congenital abnormalities of the heart. And again, the types, like the other autosomal trisomies, is non-disjunction or translocation or mosaic type. Now let's describe this karyotype. Look for the number, pairs of each two chromosomes, except chromosome 13, 3 copies trisomy, so it is called trisomy 18, and the sex chromosomes are 2X, So total number of chromosomes and karyotype description is 47 XX, comma, plus 18. This is how the karyotype is described. So this is a case of Edwards syndrome in a girl. Okay, this is another karyotype, and as you can see here, there are pairs of each of the chromosomes in group 1, 2, A, B, C. Group D, we have 3 copies of chromosome 3, and then the rest of the chromosomes are in pairs, and the sex chromosomes is of a male. So this is a 47 XY. This is a mistake. It's XY and it's trisomy 13. So this is a case of a Pateau syndrome in a male. Describe the karyotype of this 16-year-old boy. You can see there are features here, skeletal features. You can see here that the height of this young gentleman is disproportionate. He is tall, usually taller, usually the height is higher than the 95th percentile for age. And you can see here it's disproportionate as the upper half is shorter than the lower half, so the extremities are longer than the trunk. And you can see here there is enlargement of the breasts, which is called gynecomastia. And usually these males will have mental retardation and they do not perform very well in their school, and they also at puberty time they have delayed development of male secondary characteristics, and they are infertile, and this is because the testes are small and firm, so the testicular tissue is atrophied, same like in Turner syndrome, and that's why they have feminine features like the enlarged breast and infertility due to lack of the testosterone. There is the enlargement of the breast, and they have infertility due to the atrophied and dysgenesis of the testis. This is Klinefelter's, it's called Klinefelter syndrome, and the cause is the presence of the extra X chromosome. So the description of this karyotype will be the total number is increasing by 1, so it is 47 XXY, and this condition is called Klinefelter's syndrome. Now describe this karyotype. This is a karyotype of a female patient aged 16 years old complaining of delayed puberty. So you have 2 pictures of karyotypes, which means that this case is, yes, a mosaic, because she has mixoploidy. She has 2 different cell lines in the same individual. Now let's describe this karyotype first. You have a pair of each of the chromosomes, and each 2 chromosomes look similar. Now we come to the sex chromosomes. You have 1 X chromosome. So for this karyotype, it is 45, X. This karyotype, you have a pair of chromosomes of all chromosomes, and you have 2 X chromosomes. So this is a normal karyotype of a female, 46XX. So this female is a mosaic having a proportion of her cells like Turner syndrome 45x and a proportion of her cells are normal 46xx. So the clinical diagnosis of this case is mosaic Turner syndrome. And this is how the karyotype is described. 45x slash 46xx. This means that she has two different cell lines. And so sometimes they put a percentage for the cell. They examine a big number of cells, and they put the percentage they found of each of the abnormal and the normal cell lines, because it can reflect or it can give an idea تديني فكرة عن السيفيريتي بتاعت الcondition of the condition. If you have more abnormal cell lines, then it will be closer to the pure Turner syndrome and will have most of the manifestations as the classical Turner syndrome. If you have the proportion of the normal cells more, then this will have a mild clinical picture than the pure Turner syndrome. We stop here for the first part, and we have discussed the numerical chromosomal karyotype changes and how to prepare a karyotype, when to do a karyotype, and how to describe a karyotype, especially the numerical chromosomal types. Thank you.